Okay. So the results of the endurance trial were recently released, demonstrating that carfilzomib plus lenalidomide and dexamethasone did not improve outcomes in patients with newly diagnosed multiple myeloma compared with bortezomib plus lenalidomide and dexamethasone. So can you discuss the study design and some of the results?
Absolutely. So, obviously this study was designed because there was phase 2 data suggesting that the carfilzomib might be a better drug in terms of a proteasome inhibitor for combinations with with newly diagnosed myeloma. And the VRD bortezomib Lendex is the standard for right now, then that's based on phase 3 trial showing improved survival. So the question was, can we actually demonstrate in a phase 3 trial that KRD is better than VRD? The trial was designed to incorporate mostly excluding a few high-risk patients because there was um, a um, another trial that was going on in parallel looking at only high-risk patients. So these are both cooperative group trials. So we wanted to make sure we complement each other in terms of how we look at these patients. And there's increasing interest in trying to look at the high-risk patients as an individual group because those patients do have poor outcomes based on the current treatment. So we clearly need something better than what we are doing right now. And the problem is if we club them up with all the myeloma patients, then we may never learn what could be done specifically for those. So that was the rationale for the design, excluding some of the high-risk patients, but nevertheless, it did include 414 translocations and 1Q amplifications were allowed, which probably represent a majority of the high-risk patients. So I think with the exception of the truly high risk like the 14, 16, 14, 20, deletion 17p, high LDH, everything else was included in this trial. Now, in terms of the results, we clearly, even though the carfilzomib Lendex did give a higher VGPR rate compared to the VRD, that did not seem to make an impact on the progression-free survival. And we think that's most likely related to the fact um, the patients on the carfilzomib Lendex had more cardiac, pulmonary, and renal toxicity, which may have negated some of the potential improved outcomes related to depth of response. Now, one other issue or one of the characteristics of this study is that we only included patients who are not going to use stem cell transplant as upfront therapy. So clearly, when you look at the data from the endurance trial, one could argue that maybe this does not tell you whether or not to use KRD versus VRD in somebody who is getting 4 cycles of injection therapy and then going to an outer stem cell transplant. But even when we look at that subgroup of patients and look at the response overall at 4 cycles, there was a slightly higher depth, more depth of response with KRD, but the differences seems unlikely that it would translate into a significantly better long-term outcome. But obviously, that's a result that we can't really truly um, derive out of the current data. So I think in terms of, I think what does the trial tell us? I think one is obviously for the patients who are not going to an autologous stem cell transplant in the beginning, there's no reason to use KRD instead of VRD. And based on the toxicity profile and the lack of improvement in overall survival, in progression-free survival, we think VRD still should remain the backbone for combination therapies going forward because it is again, safe, effective regimen that we are all very comfortable with. And bortezomib, especially when used subcutaneously once weekly, typically does not cause the same degree of neuropathy that we have seen in the past.
Okay. And as you mentioned, this study found that bortezomib, lenalidomide, and dexamethasone remain kind of the standard of care. So
Correct.
how do you think, or how do you foresee quadruplet therapy building upon this standard?
So I think, we already have trials, some of the trials that have reported on combining daratumumab with the currently used triplets, including VRD and VTD. We do have data from the Cassiopeia trial that looked at VTD data that PFS can improve. We have data from Griffin trial showing a similar increase in the depth of response improvement with adding daratumumab to VRD. Obviously, we don't have longer term outcomes from the Griffin trial yet, but that along with another large phase 3 trial called Perseus that's going on in Europe might better define how we're going to be using the quadruplets in these patients. But the key question that needs to be addressed is, if you're going to treat someone with quadruplet, how long do we need to keep them on therapy? So those are things that are still being explored.